aggravate the pancreatitis.
Question: how the non-obstructive biliary disease actually lead to SAP? How it will cause SAP? If the stones are in the gallbladder, how it will cause SAP?
How to cause the SAP?
Yeah.
So maybe the little stone is fall into the ampulla and through the papilla, through the papilla. But the stone is enter into the intestine, into the duodenum. But maybe the papilla edema. So the edema of the papilla also can cause the pancreatitis. So a lot of people only have gallbladder stone, but also can cause acute pancreatitis.
Just professor who say, here coming by doctor here, it is stone maybe here. It is a cause of severe pancreatitis. So just to say ERCP means endoscope come from here, then EST, stone take away, is blood from here into the duodenum and take away stone. So okay, so the pain, no pain, abdomen pain is very good. But if we do for diagnosis, sometimes we do ERCP. We cause maybe acute pancreatitis. This time usually is acute pancreatitis caused by biliary stone. We usually do ERCP takeaway. It's very good. The means understand?
Yes. So, but if suppose in this case the ERCP complication occurs, then
Yeah.
like as you said that when the ERCP we do, like sometimes it can cause acute pancreatitis.
Yes.
But if it's the case of acute pancreatitis and we are doing an ERCP and it aggravates the acute pancreatitis, then what would be the
No. It is reduced.
It always
Yes.
reduces.
We move to next chronic pancreatitis. We will very briefly talk about the chronic pancreatitis. And chronic pancreatitis patient will recurrent upper abdominal pain and with dysfunction of endocrine and exocrine pancreas. So from this definition, we will know the patient have four main symptoms. The four main symptoms, the first is recurrent abdominal pain in chronic pancreatitis patient, recurrent abdominal pain, and because of the endocrine dysfunction. So the very low insulin, and the patient will present with diabetes. And the patient will have exocrine dysfunction. So the patient's digestive function is not very good. So the lipid cannot digest it. So it will lipid diarrhea. The patient have poor absorption. So the body weight loss. So these are the four main symptoms of the chronic manifestation of the chronic pancreatitis. They are also the most important recurrent abdominal pain, and with body loss and diabetes and lipid diarrhea. So it is the bile duct in chronic pancreatitis. It's a normal pancreatic duct, and it's dilated pancreatic duct, and then maybe can stone in the duct. It's very, very dilated. Also can be very severe chronic pancreatitis. And we do the operation just to relieve the pain and drainage the pancreatic juice and to ameliorate the nutrition and improve the pancreatic function and to ameliorate the diabetes and help to the good digestion of the patient. So these stones take away from the patient duct, pancreatic duct.
What was the composition of the stone?
Composition of the stones. Maybe the calcium. So at last, in pancreatic titis, we will talk about the pancreatic system. In scanning of health scanning, we have to always do ultrasound. We always can find a cyst in the pancreas. So what kind of cyst can be exist in pancreas? We know we have a pancreatic pseudocyst. In pseudocyst, maybe it's a complication of the acute pancreatitis. So the patient may be onset attack of the pancreatitis. So it's a pseudocyst. Sometimes we also have a genuine cyst. It's a congenital pancreatic cyst. In this kind of cyst, they are epithelial around the cyst. They can exudate the fluid from the epithelium. But in pseudocyst, the fluid can from the pancreas fluid, can from the pancreas. So we also have retention pancreas cyst. Also, we should pay attention to. They are also neoplastic pancreatic cyst. We know have pancreatic cyst adenoma is benign. It's benign or is malignant. Pancreatic cyst adenocarcinoma is malignant. So a cyst recovered by ultrasound. It can be benign, also can be malignant. We should pay attention to. And about the pseudocyst, almost majority of the pseudocyst, we don't take operation. We don't take operation. We just conservative therapy, and because the fluid in the pseudocyst can absorb. But when the pseudocyst is very large, and it's very large, more than 6 centimeters, and it's very long time, we should do operation. And if the patient, because the large pseudocyst feel painful, so feel abdominal pain, and we should take operation. And last, if the cyst have hemorrhage and sepsis and infection, we should do operation. What kind of operation we should take? And very easily we can do percutaneous drainage under the ultrasound. And maybe we also can operative drainage. We also can do cystogastrectomy or cystojejunostomy. We also can do the anastomosis between the cyst and the stomach, between the cyst and the jejunum. We can do the operation. And if the pseudocyst located in the body tail of the pancreas, we also can do resection of the body of tail of the pancreas.
Excuse me. In this cyst gastrostomy and cyst jejunostomy, you're opening the cyst into the the stomach directly. Now the pseudocyst has necrotic contents in it. So won't it damage the gastric epithelium or something?
We will take out the necrotic tissue. And if we do the cyst gastrostomy, so the pancreatic juice can drainage into the gastric. So this patient is a large pseudocyst and bleeding. Bleeding is the clot of the bleeding. So we do the operation to take out the clot and do drainage.
So where is the head of the pancreas here?
Where is the head?
Yeah.
Head, we cannot see the head. We just show you the pseudocyst.
So the pancreas is surrounded by the cyst, or the cyst is inside the pancreas? How is it?
It's enabling the pancreas. The pancreas is not always in the pseudocyst. Not very clear about the head of the pancreas. And the next step we'll move to pancreatic cancer. Okay, next step I will talk about the pancreatic cancer. So we will review this anatomy of the head of the pancreas. From this picture, we can see if a tumor occurs in the head of the pancreas, we will compress the CBD, common bile duct. So the bile cannot enter into the duodenum. So the bile retention. So we can see enlarged gallbladder and the dilation of the CBD and the intrahepatic duct. So the patient will present with jaundice and enlarged gallbladder. And if the mass get larger, grow larger, will obstruct the duodenum. So we can't eat. So it's the duodenal obstruction. So it's from the common pathway. And
how about the gallstones? Can it form gallstones? The gallbladder?
Gallstones.
Yeah. Because it would be concentrated, right? Obstruction. So we can have gallstones as well.
Gallstones will cause gallstones because gallbladder stones is induced a long time, not several days. But is obstruction of the lower part of the CBD, just the retention of the bile will not cause the stone. But the bile is very thick.
So retention of the bile would keep on increasing, right? The bile will increase, and the bile is concentrated itself as well. So much of bile, it can cause
Stone. No, in clinically we rarely see the gallbladder stone caused by cancer. Because it's a short period of time. But we always can see the bile in the gallbladder is very thick. So we will introduce the pancreatic cancer. The incidence is significantly increased. maybe it's the food pollution and the water pollution, air pollution, maybe so the incidence of pancreatic cancer is elevated. And the next cause, maybe in early stage, a lot of pancreatic cannot be detected. Before the detection, the patient will die. We don't know the patient suffer from what disease. So maybe in recently, the detection technique is very good. So more and more patients can be discovered in early stage or in late stage. So the incidence is increasing. But the cancer located in pancreas is very difficult to diagnosis. Even if a small tumor can induce a lot of questions. So it's very difficult early diagnosis. So the surgical resection is very difficult. Almost majority of the patient when diagnosed is later stage. So most important we should do is find early diagnosis. If the later stage of the patient, we cannot do surgical operation. So the prognosis is very poor. How poor? We can see 90% of the patients died with 1 year after diagnosis. That means a lot of patients, when diagnosis pancreatic cancer is later stage, so majority of the patients will die within 1 year. But of all the patients, 5 years survival rate is only 1% to 3%. It's the lowest in malignancy. So the prognosis is very poor. But after quick post-operation, the 5-year survival rate is about 20%. Some centers will reach to 30%. And the pancreatic cancer, mainly located in the pancreatic head, is about 2/3 is located in the head. So in this class, we'll only talk about the pancreatic head cancer. The cancer mainly is ductal adenocarcinoma. It accounts for about 90%. At the time of diagnosis, more than 85% of these tumors have extended beyond the limit of the organ. So it's 85% is the later stage. It's extended beyond the pancreas. So mainly perineural invasion and the lymphatic spread or the liver and the peritoneum metastasis. So most important we should do is the early diagnosis. And the manifestation of the pancreatic cancer. The first cancer may be the pain or the fullness in the epigastrium. When a patient feel pain, go to see a doctor. The patient will neglect of the pancreatic cancer. So when the patient presented with jaundice, the patients or the doctors will pay attention to. So we will take accelerated examination to get a diagnosis of pancreatic cancer. When the patient presented with jaundice, we will give a liver function examination. And when the bilirubin especially the direct bilirubin is very high, it may be caused by obstructive jaundice. Obstructive jaundice mainly the pancreatic tumor or CBD or biliary tumor and like that. So it is obstructive jaundice. And when the jaundice is very severe, we will also see the dark urine and the light stool. That means the bile cannot into the cannot go into the intestine. So the bile in the stool is very little or no bile in the stool. So the stool is very pale. It's very pale. Or we also call it pale stool. It's just like white. The pale stool. But the urine, because of the bilirubin in the blood, in the urine, is very high. So the urine is very dark. So it's a dark urine and light stool. The patient also will have weight loss and fatigue, and will also some vomiting and nausea, vomiting, and GI symptoms, distension, and others will have diabetes mellitus or episode of hepatitis. About the physical signs, the most important is the jaundice. If the patient will have gallbladder, enlarged gallbladder, so if a patient, the jaundice is heavier and heavier, it's more and more severe, jaundice. And the patient has no pain. But we also can calculate enlarged gallbladder, the non-tender gallbladder. We call the Courvoisier's signs. If we have these signs, we may pay more attention to if the patient suffers from pancreatic cancer. In advanced stage, so we also assess this palpable mass in a later stage. So, in pancreatic cancer, the most important, we should do the early diagnosis. So the patient, if we have following symptoms, we should have strong suspicion of pancreatic cancer. The first is the pain in epigastric or back pain. In this patient, we have back pain. In epigastric, and in less than 2 years, have pain. And if less than GI symptoms, but the GI test is negative, gastroscope is negative, we should suspicion of pancreatic disease. And if the patient have obstructive jaundice, maybe have jaundice, the doctor will easily get a diagnosis of pancreatic cancer. If the patient have unexplained weight loss, or unexplained pancreatitis, or unexplained diabetes mellitus, in this condition, we should suspicion if this patient have pancreatic cancer or not. When we have the suspicions, so next step, what we should do? We should do the blood test, and cell tumor marker. So in clinically, CA199 is have a high sensitivity and specialty. So CA199. So other tumor marker, CA50, CA, and like that is not very good. But combination of these tumor marker will elevate the sensitivity. Will have improve the sensitivity and specificity. And if the patient have elevated CA199, So we should know what happened in the pancreas. We will do imaging testing, imaging examination. So very easily we will do ultrasound. In experienced ultrasound doctor, we will find a very small tumor. And if as a doctor, as a surgeon, we usually will do the CT scanning, because in CT scanning, as a surgeon, we also can see the mass, the loci of the pancreatic cancer. It's helpful to operation. And other imaging examination, just like MRI and ERCP, MRCP, PTC, and PET, and angiography are all helpful to diagnosis of pancreatic cancer. But most common, we always take ultrasound or CT as the first step, first step of examination. Sometimes we can use MRCP to observe the dilated bile duct or dilated pancreatic duct. So it's ultrasound. We can see a mass was obstructed the CBD and dilated CBD. It's also a mass in the pancreatic head. It's in CT scanning, a large tumor. This tumor may be a late stage, advanced stage. This is the liver. This is the cava. It's aorta. This mass is located in the body, in the neck and the body of the pancreas. The distal duct is dilated. And in this patient, we can see enlarged head of pancreas. We can see in the head tube. This is a body or neck and the body of the tumor. It's hypodense mass. This is MRCP. In MRCP, we can observe the dilated CBD, enlarged gallbladder, and dilated pancreatic duct. So it's also MRCP. We can see the CBD is dilated very obviously, and bile duct and pancreatic duct also dilated. So this patient is the pancreatic duct is very severe, but CBD is a little dilated. Also the ultrasound. This is one patient. This patient ultrasound, we can find a mass. And next we do the CT scanning and found a mass in the head of the pancreas. This is also this patient and do the MRCP. We can find dilated CBD and dilated pancreatic duct. So maybe a mass here obstructed the CBD and the pancreatic duct. This is the second patient. We can see a mass in the lumen of duodenum. So clinical diagnosis is papilloma of duodenum. Very large. This is the lumen of the descending part of the duodenum. We can see a mass inside of the lumen.
The edema is still there.
Edema
of the gallbladder.
The gallbladder is not edema. edema. It's enlarged gallbladder, not edema.
Why is it?
So enlarged gallbladder.
You did-
Okay, we'll continue our class. We know diagnosis of the pancreatic cancer mainly use ultrasound and CT screening and MRCP, and we also can use endoscopy. Just the ERCP, from this ERCP, we also can take pancreatic juice, use cytology. We can get pathology diagnosis. We also, from the pancreatic juice, we can test the tumor mark or the gene detection. This all will help to the diagnosis of pancreatic cancer. This is ERCP. This is a duodenal scope into the papilla of the duodenum. We can insert and do the cholangiography. So we also can combination between the endoscopy and ultrasonography. Just means